Okay, and also, like I said, it's being recorded so we can show it maybe another time to other students. Everybody got a clicker?
Oh, sure.
Does everybody not have a clicker? We can put it that way. Who does not have a clicker?
Does everybody have a handout?
No. We're sharing though.
You're
I
sharing.
will go borrow one and go make copies.
Okay. Last thing then is guest lecturer, Mrs. Karie Minaga-Miya. She's my favorite risk management person.
And you're my favorite high school.
Thank you.
Oh.
And so I want you guys to pay attention, be engaged. Very important. If I walk around, you guys are not engaged, you're surfing on your computers, doing whatever else, then we will have all computers turned off today. You understand?
Understood.
And next week you can start screwing around your computers, okay?
Yes, sir.
Thank you, ma'am. Okay. Karie Minaga-Miya, she is the risk management leadership for the urban south region, and she's stationed at Utah Valley Regional Medical Center. She's going to talk to you about what risk management is. There's probably some misnomers about what it is, and
These are the objectives.
these are your objectives, and she's done this before. So you will maybe get the opportunity to work with her on a personal level if you work in the urban south region and you do something bad. Okay?
Not necessarily. Oh, no, don't do it that way.
She is probably one of the few true nursing advocates that I work with. She will have your best interest in mind every time. Okay? It's all yours.
All right. So the most important thing is when you leave the little clickers here for me because I will be in big trouble if I don't take all the clickers back. So that's the most important thing. If you don't remember anything, remember that. Or else I might have to start working for Troy. So these are the objectives. I did this for a class before you, and Troy indicated that it was really helpful for some of the students. So I hope it's just as helpful for you. The clickers is really so that you can help me be a risk manager today. So I'm going to teach you a couple of little simple.
If you really can't hear, you got to speak up.
Yeah, did I have a mic last time?
No.
Because I'm kind of shouting. All right, there's a thing.
Okay.
You guys can move up.
A fan. Okay, so I'll speak really loud. Okay, so so sorry if I sound like I'm shouting, but I can shout. These are the objectives that I think your class prior to you said that was really helpful for them. So I'm going to teach you a couple of little theories about being a risk manager, and then those little clickers, it actually helps you make some risk management decisions. So so we're going to just test this out really quickly. So can you name who this physician is? Is it A, B, C, or D?
He looks like he's 15.
Yeah, you're not seeing this show. Can we do the clicker there?
Okay, hang on. There you go. Go ahead and vote. All right. So, 69% of you said Doogie Howser. The 22% of you are probably too young to remember Doogie Howser MD. So, how many of you know who Hawkeye Pierce is? Okay. How many of you know who Dr. Welby is? Oh my gosh, it's one person. Doogie Howser was a young teenage prodigy, and he graduated from high school and medical school when he was just a teenager. And his name was Doogie Howser, MD. So I think most of you know him as Dr. Barney, or there's no such thing as a Dr. Barney Stinson, right? He's in a current movie called, I had to write it down because I've never seen it before.
How I Met Your Mother.
Yeah, How I Met Your Mother. So I've never seen that show, but anyway, that just kind of that was just a test to see if we could, to see if this thing works. So, okay, first of all, let me just tell you a little bit about risk management in healthcare. How many of you have heard of risk managers or risk management? So I think most of you have heard about this. I've been doing this for a really long time. In fact, I've probably been a nurse for longer than many of you have been alive. But risk management, when I came into, when I finished graduate school and I wanted to do some risk management, it was a brand new field. It's a spring off from quality, and risk management is just a relatively new field in healthcare. So it's really trying to understand all the risks there are in the hospital, and we don't always just get involved when there's a lawsuit, but we can. You know, somebody was asking me before how many actual depositions or hearings and things like that we have, and we have a fair number of them. And in fact, I was supposed to speak next week, but we had a fair hearing next week, so I needed to move it up to today. So there's probably a week that doesn't go by that I am not preparing some nurse or doctor for a deposition or a hearing. But so that's one aspect of it. Another aspect of it is if there are events, serious safety events that happen in the hospital that are potentially compensable events, such as a fall with injury or medication error, then I get involved in all of those kinds of situations, and we try to mitigate any damages that the patient might have experienced. So those are all the different ways that we get involved. We're also involved in purchasing insurance and making sure that you have good insurance that covers your practice. So a big organization like Intermountain Healthcare, we're going to have, you know, we have a air ambulance service, our helicopters, so we have air ambulance coverage. We have, you know, in case we have fires, we have, you know, property damage types of things, fires, floods, those kinds of insurances. But our biggest hunk of insurance is workers' comp as well as professional liability insurance. So we're going to spend most of our time talking in reference to that. So how do we handle risk management in healthcare? How do we manage that? Well, there's financial risk management. So sometimes we buy insurance in order to cover our risks in insurance in clinical care. Now, why would we have that? So in a minute, we're going to talk about the elements of negligence, and nowhere in there is there a word intent. So, you know, even under the best of circumstances, even under the best of care, human error can occur, because really to this very day, no matter how long you've practiced, I have never been able to predict the future. I haven't, and I don't think any of you could predict the future either. So if you know what this patient's going to be doing 30 minutes from now, wouldn't your practice maybe be a little bit different? So you know, that's where professional liability insurance comes in. Even under the best of practices, you know, negligent care can occur, and we'll talk a little bit about that. When we develop new programs, so, you know, if you're bringing in a new piece of equipment, you know, I've been around clinically long enough to know that we moved from just regular abdominal surgery to laparoscopic surgery. When we first started doing laparoscopic surgeries, some of those first few cases, you know, I think people were a little bit less talented or skilled at maneuvering the equipment. And so whenever you have a new program or a new piece of procedure or whatever, I think you have some liability and risk there. And also, I talked about human capital. It's really great to see so many new nurses because, you know, I think we're always looking at what is the best staffing ratio. I think we're seeing that more and more patients are sicker and sicker when they're in the hospital. And we're always trying to figure out, are 12-hour shifts good? When are our errors or mistakes being made? Are they at the end of a 12-hour shift? Are they end of a series of 12-hour shifts? Or at the beginning of shift? we're able to look at all of those kinds of things. And we always evaluate when an event happens, whether workforce fatigue has some kind of impact in that. You know, I think we're a little bit beyond this, but I think some areas we're still looking at, you know, what is the basic educational level that we want our nurses to have. You know, when I started practicing, we still had, what do they call them? I forget now. But they're trained, you know, the nurses that were trained at like the old St. Benedict's Hospital, the diploma nurses, where they actually just practiced there and they got a diploma from the hospital. We also had associate degree nurses, bachelor degree nurses, and masters, and now we have doctors of DMPs, doctors of nurse practitioners. So we have a whole variety of levels of nursing practice, and what is our basic level of entry? And that's a big question a lot of times for a lot of different areas. And then how do we teach critical thinking and learning, and how do you learn new technology? Like I talked about laparoscopic procedures. We have a lot of legal and regulatory requirements. Back in the day, we didn't have any regulation called HIPAA. How many of you have heard about HIPAA recently?
We know HIPAA.
Yeah, I know. So back in the day, it was just privacy and what is good practice to keep your patient's information private and secure. We have technology. Electronic medical records is something brand new. I charted on paper, and it took me a long time to transition over to electronics. And then we can never de-emphasize the impact of natural disasters and hazards, especially, you know, I think we've heard about some of the impact after tornadoes at Jackson Memorial Hospital. There was also all the issues that went on after Katrina. So I think more of the natural disasters, those are all issues and concerns that we have to prepare for from a risk perspective. So most facilities have some type of event tracking system. And the reason why we track it, and the reason why what we track there is confidential, is because we need to track and trend what are some of the issues going on. In the state of Utah, the state of Utah, the legislature values peer review and case review for patient care improvement so much so that they have protected the information in those event systems or incident systems. Now, why do you think that is? Does anyone have any thoughts about why the state of Utah wants to protect that information from being discovered? Yes?
Probably because no one's going to come forward because there's
Absolutely. So if you were called, say there was an event and I called you and I said, you know, can you please come and talk to us about, and let's do a case review, and we want to do it under the umbrella of you know, a case review, peer review environment. If you knew that later on, if those patients wanted to bring legal action, would you be as open and forthright? I think it would have a chilling effect. And the legislature wanted us to really get together and improve patient care, and that's why they protect that information. So wherever you work, one of the key things that the risk managers will point out to you is that if you do have an event, when you're documenting it, they want you to document the factual situation around the event. For instance, if a patient fell, you want to document that you found the patient on the floor and your assessment for that patient. But you don't want, risk managers don't want you to document that. For details of the fall assessment, please see the event report. They don't want you to do that. They want you to document factually what you're doing and assessing a patient on, but they don't want you to document the fact that you did the event report, because that is confidential. It's protected, so that when we do the investigation, everyone can be open and honest about that. So that's just a little background behind tracking and trending various events, complaints and grievances, and serious safety events. When we identify maybe a trend in a particular area or a certain situation that keeps coming up, then we have an opportunity to mitigate those damages, and we can really do an intense review of that particular process to see if there's a way that we can help you practice safer, and that's risk mitigation. And if there's situations that just pop up, you know, that you just need some professional liability coverage, that's where risk financing comes in. So that's just the risk management process. So this is your first voting question. I'm sorry legislation. What do you think it is? A, B, or C? All right, go ahead and vote. You want D? So, yes, you got that correct. It states that a nurse can tell a patient that they're sorry. If you say, I am so sorry, I am totally responsible for this, and we will do whatever we can. We'll give you as much money as you want to make to take care of this situation. Do you think that's part of the I'm sorry law, or do you think that's gone a little bit too far? Yeah. And I exaggerated it because when you're involved in an event, you're so emotionally involved in that situation. And we see a lot of physicians, nurses, they do that. They're just so distraught about being a part of this event. But make sure that you say you're sorry, that you empathize with what they're going through. But, you know, to just be a little bit reserved and not throw yourself on the sword over this particular situation. Make sure that you always call the risk manager, your supervisor, or your manager before you know, totally throw yourself on the sword like that. So, so this is a question as well. So we're going to apply risk management techniques to real world projects. So which one of these projects, A, B, C, or D, do you think are areas that risk management can help make a decision? Okay, go ahead. Good. 77% of you said all of the above, and that is really true. Actually, each one of these, and I can go back and just review this. So on the one where it says evaluate whether it's financially appropriate to hire a physician 24/7 to cover labor and delivery unit for emergency situations, I actually did that. What I did is I pulled all of our labor and delivery cases, and I looked to see what time frame they happened and how much those labor and delivery cases cost us. And what I found is a lot of these cases happened during the times where we didn't have a physician in-house. And I added up all the dollars that it took to resolve those cases, and I said this could easily cover a salary for somebody to be hired, you know, within the facility. So you can use risk management data to validate this kind of a hiring. You can also look and see what kind of trends there are to see what nursing education you need. And definitely you can look at medication errors, and you can look to see if barcoding can help in that area, and to evaluate your falls. So really all of the above will work. So this is not a voting question. This is just kind of a little bit more theory behind how I evaluate a nursing action to see whether you have negligence or not. So it seems pretty easy for someone to actually file a lawsuit and to sue you for malpractice. And I think a lot of nurses are saying, you know, gosh, is there anything that we can be defended on? I mean, it just seems so easy to just hire a lawyer. Well, number one, I've seen a decrease in the number of lawsuits that we've had over the last few years. The rationale, I think, is because plaintiffs' attorneys, they're probably not wanting to take a whole lot of cases unless they feel like it's a pretty good case, because they do have to put some money into handling those cases. And just because you file a lawsuit doesn't necessarily mean that they recover any damages. So every lawsuit that's filed for medical malpractice, they have to establish these 4 elements of negligence. First of all, you have to establish what the standard of care is in that particular instance. And there isn't a book called Standard of Care. They look to your Nurse Practice Acts, they look to your policies and procedures and guidelines, they look to your professional organizations for various standards. So if you belong to the OR nurses or the emergency room nurses, they look to see if there's some standards that are built around your particular specialty. They look at case law, and then they look at expert testimony. So medical malpractice is the only area. This is similar to a personal injury case. It's in the same area of law, but the difference between a personal injury case, say a car accident, versus a medical malpractice case, is that in medical malpractice, you need an expert, so you need a nursing expert to testify against nursing standard of care. You would never have a physician or a respiratory therapist testify against a nursing standard of care. Yes?
Would that be you in that case? Or somebody like you?
No, it's usually a nurse in your particular area of practice. It rarely is the risk manager, unless the risk manager is the one being accused of negligence.
Okay.
So if you're an ICU nurse, they would look to another ICU nurse.
Okay.
Sometimes they just look at nursing in general,
right.
But we try to have it be very specialty specific.
Yeah.
And if it's a bigger hospital, the Utah Valley Regional Medical Center, we wouldn't try to get an expert from an American Fork Hospital ICU nurse. We try to get the same kind of facility. So that was a good question. So that's the difference between personal injury and medical malpractice. So once you establish what your standard of care was in a particular situation, then you have to show that you breached that standard of care. And then you have to show that that breach of the standard of care actually caused the patient's injuries or damages. So damages in a medical malpractice case pretty much always equates to some kind of a dollar figure. And this, I think most of the time, what we do from a risk management standpoint is we focus on the standard of care and whether that standard of care was breached. And then when we get to causation, and we actually look at causation as well, but to actually figure out the dollar amount, we usually don't do that just purely from a risk management standpoint. So now you've had all the training that you need to be a risk manager. So we are going to go through a series of cases, and I just want you to tell me how you would handle these situations. So a patient has just suffered a fall or a trauma while hiking in our local mountains, and the spouse has come in with to the emergency room with the patient. And you notice that the spouse is answering all the questions about what happened during the fall. And the patient is able to answer questions, but is not allowed to answer questions by the spouse. What would you do in this circumstance as a nurse taking care of? So that's really good. Inform the spouse that part of your assessment is to assess their needs. What if the spouse is hovering over that patient and not allowing them to speak, or it looks as though they're intimidated? This is a really tough situation, right? So if you notice that, make sure you document some of those kinds of observations. But you know, we've had nurses who have tried to very delicately ask the spouse to, you know, go out and fill out some paperwork or do some other things while they're, you know, and try to get them along to see if they can answer some questions. But either one of these answers are correct. But make sure that you're always your actual patient is the patient, not the spouse, and that's a tough situation sometimes in the emergency room. Yes.
So in a situation where you suspect abuse, how do you document without, like, how do you know it's facts? You know, like, you always want to be factual without, like, stipulation or opinion.
So under this situation, you would say, you know, patient's spouse answering all the questions for the patient. And just describe what you're observing with this patient. So, yes.
I don't think that always means abuse. I mean, I know there's people that really, really, really don't like going to the doctor.
Right.
And their spouse may be answering the questions because they feel for that other person and realize that they don't want to be there.
Right.
So it's not always a cut and dry situation.
Right. So those are some of the push and pulls about that. So if you just describe what you're observing, and you know, your first step would be to be what 75% of you said is to explain to the spouse that we need to assess, you know, your spouse's ability to answer questions and to comprehend what we're saying. And that's a good place to start. And if they allow you to ask them questions, then, you know, that's one thing. But if they refuse to let you do that, there's some other things that you need to probably do to assess your patients a little better. But these are all situations that, you know, I've dealt with various nurses with, you know, throughout my history, which is a lot and spans many different facilities. So, okay, here's another case. A patient's now in your emergency room and they have fallen at home. The family members who are there say they did not witness the fall, but they heard the fall in the next room. The admission vital signs are, as you can see there, the patient has now been cleared for discharge, and this is the only set of vital signs you have. What do you do? Oops.
Oh.
Sorry. Oh, excellent.
Yeah, good job, guys.
You guys can all be risk managers now. That's the perfect thing to do. I mean, you know, and a lot of times you're looking at this patient, and once again, I said, you can't predict the future. So if this patient then comes back, and I can't tell you how many cases we've had where this has happened, the patient then comes back and has had a subdural bleed, you know, and they said, well, it was that high blood pressure that caused this patient to bleed, and so really it's all nursing's fault. And it's, I mean, even though that's kind of outrageous allegations, it's a little bit hard to defend that not getting a second set of vital signs. So anyway, good job, you guys. All right. Trauma patient is admitted and you're called in for a case review with me, and you've received many verbal orders that have been completed while caring for this patient. To prepare for this case review, your educator asks you about the verbal orders and if you completed them. Where do you look for your interventions on this patient? Now let's assume that the verbal orders were never documented by you or anybody else during this particular situation. Where do you look for them? Once again, good job, 100%. Now, how many of you, if you've worked with me, you know that I actually pull the bills as well. Because I do know that we sometimes we have, you know, all these little charge sheets that are running around. We always bill for the services that you provide. So there are other evidences besides the nursing notes to see, you know, what you've done for your patients. But really, we look to the nurse's notes. That's where your documentation for what you've done to intervene in your assessment on how the patients responded. So, so that is the primary place where I look to see what you've done for a patient. We do look at, you know, the vital sign sheet, the medication sheet. We look at respiratory therapy orders. We also look at the bill to see if there were things that were billed for that maybe you didn't necessarily charge. But the primary area is the nurse's notes, so good job. So really, this is a summary of the bottom line. If you're doing a procedure, make sure you document it. If you're assisting with a procedure, make sure you document, you know, how the patient's responding to those, such as, you know, how they're responding to the medications when you started it. If someone's asked you to give a medication and you don't write down a verbal order, and every facility has a little bit different way of whether you can take a verbal order or not. But if you don't document it down and you haven't actually received an order, or you have received an order and you haven't documented it, you know, it could look like you're practicing medicine without a license. So make sure that you write down those orders that you get. So if you have like a chest pain protocol, most ERs have what they call a chest pain protocol, and there's different protocols in each of the different units as well. So how are those protocols different that you don't have to get an order for doing all of those things? Usually protocols are put together through a multidisciplinary process where doctors, nurses, and everyone gets together, they approve the protocol. And so it's somewhat deemed that those are physician orders on those protocols, but more and more we are going towards making sure that there's a place for the physicians to sign as to if you followed a chest pain protocol and you've ordered, you know, enzymes and chest X-ray, and you're going down a particular protocol. They check those off, and then the physician signs those, and that's how we usually get physicians to say that they've ordered the items on the protocol. Does anyone have any questions about protocols? Okay, that's pretty clear. You know, we have had situations in which physicians said, hey, listen, just go ahead and do this. You don't need to call me, especially in the middle of the night. Just go ahead and do this, and I'll back you up, no matter what. So how many of you think that that's a safe practice? How many of you have actually participated? Well, you don't have to answer this. But I've met with nurses in the past where they said, well, the physician said always, if this happens, go ahead and do it, and we will back them up. And when the nurse turned around and looked, they were as far back as they possibly could be. You know, when push comes to shove in a deposition, the physicians are going to be asked under oath, did you actually give this nurse this order? And truthfully, they'll have to say, I did not in this particular instance. And so, you know, just don't put yourself in that position. You know, I mean, there's a reason why they went to medical school that included being called in the middle of the night regarding their patients. So don't be afraid to speak up and talk to your patients in the middle of the night. And then I think I've already talked about this. If something happens, make sure that you document the facts of your assessment and what you did to to intervene for that patient, and then fill out the report. Yeah.
I just have a question on. So I had a physician that basically sharpied a point on a patient and said, if their lungs collapse, take this 18-gauge needle, jam it in, and then call me. And I was not really comfortable with that, but I want to know what I should do, or because we don't have, we're at a small hospital, we don't have doctors on staff. There's nobody there. So, you know, how can you do what's right for the patient, but save your
right
as well?
So, you know, you'll have to, so every facility has to evaluate what their nurses can and cannot do. So number one, doing a procedure like that, it's an emergency life-saving procedure. And so you'll have to look and see if you have any policies, procedures, or protocols to address, you know, a pneumothorax. There's an emergency pneumothorax, probably. And, you know, how do you intervene for a patient if they experience one of the major risks and known complications of, I don't know, ventilation or, you know, I mean, obviously that physician knew that there was a potential for pneumothorax in that patient. So that's where you would go. That's where you would fall back to, and you know, if you're uncomfortable in doing something, whether you have a protocol or not, you need to go back to through your chain of command and make sure that you tell somebody that you're uncomfortable, you haven't been trained in this. So it would, no matter whether it's a procedure like that or you're transferred to a unit that you're very unfamiliar with. You know, if you're asked to do something that's a little bit different than what you've been trained to do, you need to be able to ask questions and go up through the chain of command to get training or you know, to be able to address those situations. So is the physician close by, like within
Oh, they're
30
probably about
minutes?
15, 20 minutes maybe away.
Does your facility have an emergency room?
No.
So those are all the kinds of, you know, procedures or protocols that your facility will have to address.
So basically you're saying it would have to be a protocol that's put in place that, including training and whatnot to do those type of things.
And that's what a risk manager will advise you to do. If it's, you know, and obviously if you're you know, on an ambulance, that's going to be totally different. But you're usually trained for those kind of emergency interventions. So, you know, if you often have patients that might have a pneumothorax, that might be a good protocol to develop and to have their training. Yes.
What about for standing orders? Like, is that covered, like, as far as, like, for risk management, is that, like, if there's, like, for my facility, like, for different procedures, like, if they're nauseous, like, we can just give them stuff, and I don't necessarily every time have, like, a physician, like, writing out the prescription for that.
Right.
Is that?
I do know that risk management doesn't really control standing orders. I think that's more of a joint commission or a regulatory requirement that I think they're moving away from standing orders and they're wanting to individualize, you know, orders for patients. So, I mean, really your quality people are the ones that address standing orders. And I think we're moving away from standing orders a little bit more. So then you asked me the question, what's the difference between a protocol and a standing order, right? So protocols are a multidisciplinary team that put that together. Standing orders are generally physician specific and they vary from one physician to another. So I think those are some differences that every facility has to grapple with. And so I think more and more they're moving away from standing orders. So do you think I'm telling the truth or do you think there's more out there that I'm aware of?
I feel like you're telling the truth. No? Are you not?
I am from where I stand, but you know, a lot of times what I'm saying versus what you guys are experiencing on the front line could be worlds apart. So this is my reality check when I get to come and talk to you guys. So are you seeing still a lot of standing orders?
No, they've given them away. It's more protocols.
Where I see some standing items, and they're in the OR, there's you know, the physician's recipe card for, you know, what they want put on their OR table. I see some of those kinds of things, you know, where they have more of a, it's not a standing order, but it's what they use for sutures and things like that. But I think more and more people are moving away from standing orders for, you know, I don't know.
Is that
because in litigation, a standing order, the doctor's liable, and a protocol is not, because he didn't sign it?
No, actually, it's just the opposite. The
Is it?
protocol is more protective of everyone, whereas a standing order, you know, if it's outdated, if the medications are outdated, you know, really when there's a standing order, you're being asked to make a medical judgment about medical treatment.
I have another question too. Who decides when to do a case review? Is it the physician, or is it just,
It can be anybody. A lot of times I coordinate with the physicians involved. Sometimes we just do it with nursing. Sometimes we do it with nursing in pharmacy, nursing in respiratory therapy. So it depends on the case. But
I've seen one
sometimes
where they did an intensivist did a thoracentesis and hit an artery. The lady had to be rushed back. You probably know that one. Oh.
Well, you know, those things,
Dr. Mitchell had to open her up, and
those kinds of things happen.
yeah.
You know, they're known complications.
Right.
And so, to me, we don't have to review known complications. If you are right there, right on top of it, and you
A lot of times now they're using like an ultrasound to find, you know, where to go instead of just poking.
Right. And I think with better technology, we can actually deliver safer care. All right. Did I answer all the questions? Oh, okay. This one should be an easy one. Are event reports discoverable? Do you know what discoverable is?
No, I just put yes.
Well, let's see
Perfect. So discoverable means, when an actual lawsuit is filed and you're gathering data, that part is called discovery. So during a lawsuit, can the event report be discovered by the plaintiff's attorney? So I kind of gave you the answer to that, but I didn't tell you what discoverable is. So you guys are all kind of right. So it's not, because it's protected. Remember, I told you that it's protected. Okay, so I know there's a lot of questions. When do you think that an event report might be discoverable?
if you document the report.
Yes, whoever said that. If you document that, see my event report for the details of why this respiratory therapist was guilty of this or whatever, you know. If you just document that you did an event report, it raises the question as to whether that event report can be documented, can be discovered.
If you have a patient and you refer to the event report with that patient, and that patient say, and that he knows that an event report was filed for it?
Patients often know that, quote, an event report has been filed, and they ask for it, and we rarely, if ever, give it to them. I've never released an event report in the 20, 30 years I've worked in this region. Never.
Okay, so only if it's referred to in the medical record can you?
And I only do it when a court orders me to do it. Really, it has to go to a judge, and the judge will have to order me to do it before I do it. And I probably, under those circumstances, I've only released one. And it wasn't in Utah County, by the way. So, okay. If a parent told you that the sticker on their baby's thigh did not match the name on the baby's foot and the mother's arm, you would do which of the following? Very good. So this actually did happen in my career before, where the identifiers. Back then we used we put it on Tegaderm and put that the Tegaderm, we put the stamper plate on that, and we put that on the baby, and that didn't match the armbands and stuff. I think we have more sophisticated methods of doing that now, but at that point in time, that's what we did. And the mother mentioned that all the names didn't match up to what she was wearing. So she really, and newborn babies, they often look very similar. And she just wanted to make sure that this baby was her and her husband's baby, and so she wanted genetic testing done. So I paid for genetic testing to show that this was her correct baby, and in fact, so I mean, I think at the time the nurse says, "Oh yeah, sorry, we made a mistake," and really didn't do any follow-up, and we didn't remember exactly what the nurse did. So make sure whatever you do to follow up, that you make sure that you document carefully what you did to follow up on those kind of situations. Top 3. So here's an interesting question. Look at these 3 things. What do you think are the top 3 high volume nursing event types? And this is based upon national data when I attended a national risk management meeting. Very good. 91% of you said medication errors, falls, and patient care and treatment. And that is absolutely true. More and more, though, over the last maybe year or so, billing issues have gone on the rise. And so I have about 3 nurses in my department that does a lot of the complaints and grievances. And our billing complaints have gone kind of skyrocketed right now. I don't know exactly where the trend's going, but still, medication errors, falls, and patient care and treatment are the major areas. So, why is risk management so important? Unfortunately, events can happen and it can impact patient outcome and be very, very costly. Which type of event had the highest cost associated with one event? So, the one event high cost.
Like per incident or?
Yeah, per single incident.
Oh, that was okay.
Well, but you know what? Depending on what kind of incident you have, it could be any of these. So across the country, because we have tightened down on our blood administration processes, we probably only have maybe about 10 maximum deaths across the country due to ABO incompatibility. So if you have one at your facility, that would be huge. So whoever answered lab and blood administration, I think you could be correct there. Patient care and treatment, any of these situations I talked about can lead to that. Medication errors, depending on the medication you give. So if you give, just think about all the different medications you give and think about the consequences of giving either too much, not enough, wrong medications. Those can all impact you as well. Falls, I think that's a good answer as well, because if you have that patient who fell, so say instead of falling at home, he fell on your unit, on your shift, and he was on anticoagulations, or she hit their head and they had a subdural hematoma. So they can have neurosurgery, depending on when they fall, how they fall, what they land on. Falls can be very, very bad. That's why falls, medication errors, patient care and treatment. But these are all areas that we watch very, very closely.
So speed was less high.
What's that? It can be the highest, but I actually, in my experience, falls are the highest. Actually, so really any of these could be correct, but in my experience, falls are. Okay, if you're involved in a particular event with your patient, and you want to do a disclosure. You want to tell the patient that something has happened. Which one of these things should not be part of the disclosure? So I already kind of gave you the answer to that a little bit. If you can obviously, when you apologize to the patient and you say, I am so sorry for what has happened. I'm not exactly sure how this all happened. How many of you have been involved in an event and knew immediately exactly what happened that caused all the little steps that either went right or went wrong that caused an event to happen? So you knew exactly what happened. So I always caution everybody, because even if you think you know exactly what happened, there's always something that's not, that you might have some questions on. But if you do, if you know that this medication was switched for this medication, when nurses or doctors call me, I tell them to be forthright and honest with the patient, and just say, what we switched these two medications. I'm not sure exactly how that happened. We're going to look into it. I just want to be forthright and honest with you and let you know that you received the wrong medication. That always feels so much better than, yeah. Did you wonder how it?
Yeah, I just wondered if that was like beneficial or if it's just like.
Yeah, so just put yourself in that position. If you were a patient and somebody mixed medications up, and all of a sudden you can see them doing, hanging an IV, running more lab tests, and you're going to be wondering what's going on. And family members or patients have always said, thank you so much for being honest with me. And then they'll say, what are the adverse outcomes from this? And a lot of times you don't know. And I say, at this point in time, we don't know, but we've got the best doctors and nurses working on this. I actually also ask the patient, I know that this isn't our usual practice. I want to make sure that you're comfortable having me take care of you, or having, my colleague take care of you. And so we always give them the option of saying, can we switch the assignments up a little bit for you? Will that make you feel safer? And they always are appreciative of that. And really, it's about 50-50. Some people say, no, it had nothing to do with the nurse. I trust this nurse, and I want you to continue taking care of me. And then there is others that would say, it might be a little bit more comfortable for all of us if we switch that the assignment. So always make that offer in a very neutral fashion, so that they have that option of switching it out. And actually, sometimes it's good for the patient or the nurse as well to not be put in that kind of a situation afterwards. So this isn't a voting one. Disclosure and apology has a major impact in the field of risk management. And back when I first started, disclosure was just starting to take hold. So I think so many people, insurance people really, they said, don't disclose, don't apologize, because people will think that you're admitting guilt. And so just think if you were the provider and you were involved in this particular situation. Sometimes you're your worst judge, and really when we have an event, we actually have two groups of people that are affected by an event. The patient and their family, and the other group are the providers who had a hand in the event. So I think most facilities have what we call an adverse event follow-up program, where we have either social workers or EAP or the risk manager. We call to make sure that the nurse is, is dealing well with what's going on. We have good follow-up and EAP that can help somebody who's experienced some of this. And sometimes the group that never takes part in this were the physicians. And we have strongly encouraged our physicians to be involved in this kind of a program as well. So, just if you've ever been involved in an event, you just know that you're second guessing yourself, and and the last thing I want to have happen is to have you lose sleep over an event that you may have had a hand in, and we don't want you to leave your career. Just think of all your education, and because of one event, you decide that you don't want to be a nurse anymore. And the very extreme side, in my 30-year career, I've had 2 people who have taken their own lives because of an event that they were involved in. And I don't want that to happen to any nurses, doctors, or pharmacists, respiratory therapists, because of an event like that. So we do have a good serious event follow-up plan. And make sure that your organization has one as well. Yes?
Well, I'm just thinking of what you're saying, because my brother-in-law died suddenly like last week. He's 27, and they didn't have any clue why he died. And it was really hard because we were trying to put together the pieces of what happened, and the people involved were really emotional about it. Like, we talked to the paramedic who came on the scene, and he was in tears, literally, because I'm sure he went through like what he should have done. He had Narcaned him twice. He had tried to start IVs, and he had hurried and got him to the hospital, done all these things to try to keep him alive, and was unsuccessful. And so it was kind of good in a way that I could tell him, hey, you did everything that you possibly could have, and there's nothing you could have done to save his life. He was gone immediately, and you did everything right. And I just saw that, like, he just relaxed. But even, like, they called his doctor to see the past his blood pressure, because part of the death was because of a heart issue and blood pressure. And the doctor said in 17 times that the blood pressure was normal. I think everybody was worried about being sued, but it was more like to try to figure out what really happened, because it's genetic. But I look at it from both sides, because you look at it from the medical side, and you want to make sure you did the right thing, and that you did your very best to try to help that patient. And I think that's true with everybody. I mean, for the most part, that's why they're in medicine.
And I think you've hit on both sides, because I think as a patient and a family member, you're trying to put the pieces together as well. But I think the medical team and the nursing team, you're all trying to put the pieces together as well. And sometimes we're our own worst judges. We're very hard on ourselves, and we're always trying to second guess ourselves. And it's so much easier to second guess yourself after an event has happened, because you know the outcome. But like I said, to this very day, I have never been able to figure out how to predict the future. And so, just remember that you can't predict the future. And I've just, if you're not there to do your very best, then you really probably shouldn't be in nursing at all. And no one goes into this profession thinking, I'm just gonna slack off today and not do anything. That's not the reason why you're there. That's not the reason why you're assigned to those patients. And so anyway, thank you for sharing, because it's eventually we're all going to be involved in those situations. Any other comments? So if you're involved, just one final note, if you're involved or you have a colleague that's involved, make sure that you, every single nurse or doctor that I've helped through one of these events, the one common thing that they say is, after this happened, no one talked to me, no one looked at me. And the patients feel the very same way. Patients and families feel the very same way. They feel like we avoid them. Is it a perception, or is it that you limit the time that you go in there because you don't want to engage in a weird conversation, or you don't want to talk about it? I don't know whether it's reality or what people perceive, but make sure that you support not only the family through an event like this. And if you're really busy, send a social worker in, but send somebody in there so that they don't feel like they're getting abandoned, and make sure your colleagues are not abandoned as well. And then hopefully someone will pay it forward if and when you're involved in it. Okay, over the last couple of years, in the risk management field, and really in quality and nursing, we're hearing the term getting to zero serious safety events. And so, if we can get to zero serious safety events, we define serious safety event as an injury that has caused major temporary, major permanent, or death that's not associated with the underlying disease process. So if we focus on that and we try to prevent even 40% of that, we'll have 1.8 million fewer injuries in, I think the 60,000 Lives Saved project was over a period of time. But just think in your organization, if you can decrease your serious safety events by 40%, how many lives or injuries you may be able to save. And if we can decrease readmissions within 30 days, we can save not only money, but we can save patients' perception of poor care. And once again, I always tell patients, we look at how stable you were on discharge. We can't predict that you might get sick within hours of leaving, as long as you were stable at the time of discharge. So that readmission within 30 days, I know we all look at that, but that's a struggle for me, because I still can't even imagine how we're going to predict what's going to happen within the next 30 days, let alone the next minute. So HACs are hospital-acquired conditions, and I know that all of our facilities are looking at hospital-acquired conditions. So those are like catheter-related infections, they're medication errors, falls, those are all hospital-acquired conditions. Okay, so URFO, that's unintended retention of a foreign object. So just so you know, across the country, this is the #1 issue in most facilities. Now, it's not because we're just reckless disregard for our objects, but it's kind of hard to ignore, like a hemostat or a towel that's left in something. If it's in there, you're going to find it eventually, and you're going to identify it. So I know for a fact that that's one of the reasons why it's such a high number. Is unintended retention of a foreign object following a procedure.
Gross.
So, what do you think if you had one of these at your event, and you're all risk managers now? What do you think the average of those costs? What range would it cost? Very interesting. I think most patients believe it's that top one, which 41% of you believe as well. But at a recent risk management conference, they stated that it was somewhere between 100 to 120. But here in Utah, we experience more in the $20,000 to $35,000 range. So it depends on whether the object that's left behind has caused some problems or injuries to a patient. But So anyway, that's a real big issue within most facilities. And this was taken from, so this is just more information. I think getting to zero, you know, I'm beating a dead horse really. I mean, there's no reason why we shouldn't strive to get to zero serious safety events. So. And this is some information from national data. The very top number there is from a 1999 Institute of Medicine study called "To Err is to be human is to err," and so I think, and that just goes to show that, you know, even as a human being, we're not perfect, and that we can actually, you know, that there are times that under the best of circumstances, sometimes errors are made. And how many of you think that patients are understanding of that?
I think they can be if you work well with them and if you're honest and forthright, like you were saying. I think they're more inclined to be working with you instead of feeling attacked or in a vulnerable position.
I think I'm really surprised. You know, I think a lot of times people say, you know, I totally get it. I know we're not all perfect, and I understand, and I appreciate you telling me about this. And we do see, I see more of these than I do not see. So, and I think we've been going for almost an hour, so I'm not sure how much more we can. But do you want a break, or do you want to just keep going and finish?
Let's keep going.
Okay.
We're on a roll.
All right. Which one of the never events criteria? So how many of you have heard of never events?
Like the ones that should never happen, like it shouldn't even be an issue.
Yeah.
Okay.
I'm probably going to answer this question. So just answer this question, and then I'll probably. Oh,
we wanted to answer it.
here we go. Okay, there you go. Did the back table answer Captain Hook?
No.
All right.
Funny.
So it is what 76% of you said, and we know where the 24% came from, right? But so back a few years ago, it really started from CMS. CMS stands for the Centers for Medicare and Medicaid Systems. So it's the part of government that manages our Medicare and Medicaid products. So a few years ago, Medicare came up with this kind of a guideline that if never events happen, that they're not going to pay for it. So they are like fall injuries that are caused from falls, infections of certain kind that are related to lines, indwelling catheters, and those types of things. So you know, I think that's why there's this big effort right now to prevent infections due to indwelling catheters. We track falls. We're really trying to prevent some of these kind of quote never events. So that's why we're tracking some of those kinds of things. Does anybody have any questions about never events? It makes sense. So those are all the things that we're really trying to prevent patient harm. So wrong site surgery, it doesn't mean that that we're amputating incorrect limbs, or that we're taking out the wrong kidneys. Certainly those kinds of things have happened in the past, but a lot of the wrong site surgeries or procedures are like if you're going to be giving a block and you block the left side instead of the right side. Those are some of the wrong side procedure cases, and we've talked about some of these other issues. So. And I already told you about the definition of the serious safety event. So, and more and more people are tracking, what their serious safety event rates are. And this is a sample of a trending sheet. So, so some pitfalls in risk management in implementing your projects. So if you're a risk manager and you've been asked to put together a program or put together advice on a project, why might your projects fail? Well, if you have lack of executive management support, if you have poor governance, tone at the top. So one of the things on tone at the top that's really a hard balance to have is, if you're involved in an event, sometimes it's really hard to fill out that event report and from yourself. If you a lot of times from event reports, risk managers will see that's more of a tattletale system where you discover an event that somebody else did, and that's okay to report those kinds of things too, because if you're the one that gave the wrong medication, you might not necessarily know that until the patient starts reacting in a different way later on. So it's always okay to report an event, but the tone at the top helps you feel comfortable and safe reporting an event that you're involved in. So, just think back at where you work and just think of what the tone at the top is there. Do you feel comfortable to report an event that has happened at your facility? And if you ask a risk manager whether events should be part of your performance evaluation, will you be surprised to hear that risk managers don't want it to be part of your evaluation? I really don't want events to be part of your evaluation because these events are process issues. They are not individual performance issues. And I truly theoretically believe that.
But couldn't it be a good thing about like how the nurse responded, how the nurse took initiative, how they dealt with it?
Yeah. And so a lot of times you're supposed to report falls no matter the outcome of the patient.
Right.
You're supposed to report any of those kinds of situations. So it can't, you're right, it's not always a negative thing. But I think it's perceived as a real negative thing. And, even, is Troy here? He even said, have you ever had to be involved in a meeting with Karie? It's, one of those really bad meetings. And people often say, they're like, oh, I haven't seen you for a long time. I really like you, but I hate working with you. And those of us in risk management, we get that a lot. One of the things that we really like is transparency. We love to be transparent about what we're doing. We like a culture of safety, not only focusing on safety, but feeling safe to report errors and issues. And we like to look forward. We like to try to learn from the past and apply it to the future. So those are all the things that I think you need to evaluate when you're implementing a project. Yes.
So I'm just kind of off topic, but event reports, like, do you need to be done for like certain things like rapid responses, right, and like those kinds of things? But what about if the patient just gets like angry and like, do you want an event report?
Absolutely. So one of the things that is increasing is workplace violence, and it's not that we're being violent with each other; it's that our patients are being violent towards us. We're taking care of more and more patients who, either from their clinical condition or whatever, but we have nurses and and patients and people at the bedside who are getting verbally abused, physically abused, and really we have no tolerance for that. You have a right to be protected, and believe it or not, that's been really hard for us to get across to our nurses, because I think nurses, we have all worked in an environment where we're taught that we have to put up with it. It's just part of our job. And to a certain degree, some of it is true, but you know, I think we don't have to put up with it. And you know, I'm not sure how we can encourage nurses to report verbal abuse and physical, especially physical abuse from our patients. But I strongly encourage that, you know, across the board.
So you're saying we don't have to put up with patients that hit us. What if their mental status is not there? And I was hit 7 times on Saturday, but I can't do anything about it. I can just need to be taken care of.
So you need to make sure that you let somebody know.
Oh, I know.
And you know, and if there's a way to restrain those individuals, and you know, it's really hard to restrain patients anymore, because if we get an order for restraint, whether it be a hard restraint, a soft restraint, or chemical restraint, we have to have orders for those, and we have to have appropriate assessments for all of those kinds of things. But make sure that you fill out an event report so that we know what patients are violent. You know, if you work in the recovery room, you know, PACU, and a patient's coming out of anesthesia, we know that sometimes those patients can be flailing about, you know. And I did have a physician one time who got hit, and the physician just turned around and smacked the patient back. Well, you know, that, you know, I think common sense will tell us that that's probably not appropriate. But the patient, the physician said, well, he hit me. And we're like, but he's coming out of anesthesia. So we live in this dichotomous world where we're taking care of patients who are maybe not within their total cognitive ability to manage those things. But I think to put up with it and not file an event report, we're not keeping a trend of what patient is a violent patient. So, did you report to employee health?
Employee health was charged herself, like, don't give me this patient back tomorrow. She has PKU, and so she's just not there.
Yeah.
And the next nurse is like, how come she keeps saying don't hit me? I'm like, because I said it to her all day yesterday.
Yeah. I know. I mean, it's careful balance, but believe me, risk managers don't want you to be hit, so they want you to report those. So I hope you're doing okay. Call me next time. Anything else? I think we're almost done. Workplace violence really bothers me right now, and you know, and I wish I had a better answer for you, but I think you are totally appropriate to report it and say that you need a break with this individual. And when the whole unit doesn't want to take care of a patient, then you know we need to do something about that. Good job. All right. You have a whole hour to do whatever.
Stay here. Thanks, Karie. Did you get the email?
I got it. I will make sure.
Before you leave, turn in your little thing.
I need the
They'll probably use 12 plate.
clicker.
I have a question for you. I was just curious, how do nurses get a case review and not? Usually doctors set that up. I've seen things that probably should, especially with the PAs that do intensive care. Experimental medicine before it caused a guy with bone arrow blind. Are you giving so much anticoagulants above what it should have been? Break up a clot.
Here, Troy.
Completely experimental. And they didn't have any informed consent or anything. I think they should have like case review on some of the things that they're doing. That's how I'm doing.
Are there other
Troy,
Yeah.
we're going back to class?
It's
So just so you know that every trauma clinic is reviewed by trauma clinic about more than
that's probably never, you know,
Go ahead, 20. So Karie, how many go in these?
just whatever. Yeah, well, you know, and I think those cases that talk they're all together.
I gotta go to a meeting, please.
Okay, see ya.
They're up there on the table.
Okay. So that gives me a little it does. It's more than just that. And then on top of that,
I think they should be overseen. Surgeons are never.
the other thing that they American cardiology surgeons, they come in every 3 years and read about so I think all close cases are evaluated by an outside entity. So I know that they stand publicly. So some of it goes on without
It's scary. He made his kid go blind, and we were all complaining about it. And there was no informed consent. So sure, that patient the bleeding out of everything. So
there's no reason why
I do. I went and talked to the case manager, and it was it was really bad. Tell Dr. Albert got on it. All the nurses were really I did it. But he's so happy about it.
We have all of Karen's clicker back. Okay. All right. So I don't know if Troy has changed his submission date for portfolio submission 4, but mine has been changed till next week. Okay. She gets an A. All right. No. All right. So there were obviously some questions about portfolio submission 4. Okay.
Yes.
All right. You don't have any questions about portfolio submission 4? Okay. All right. So the first section is professional development. All right. And this is a place where we're going to help you to look and more three-dimensional. Not that you're just a nurse that has never done anything. So if you have been on any committees, whether that is with SNA, whether that is in your current job, any associations that you belong to. If you belong to the ENA, this would be a place where you put that. All right, Emergency Nurses Association. All right, if you are a member of SNA.
What if you were?
Yeah, one
Put it
per
there.
semester.
Put it there.
Okay.
I will tell you that when you're coming in for a job interview, if you are currently a student and you are currently a member of SNA, it usually gives you some points as you come in for an interview, because managers saying obviously you are involved in things. It's the most worthwhile $5 you can spend. Okay. Any special projects that you've been involved in? Did any of you sit on the committee when it was being discussed about revamping the nursing uniform for UVU?
Nope.
Okay. If you did, that's great. All right, put that down.
Put that on.
If you have been in the area where you're working, been on a project, the manager says we want you to help sit on this group to redesign. Yes.
What if it's not a medical job that you
Doesn't matter.
for? Okay.
Doesn't matter. It's showing depth of type of employee that you're going to be. Okay.
Having charge of inventory.
How about had a baby?
No, having a baby is not a special project.
I think it is.
I don't know.
Okay, listen, guys, listen.
There you go.
If you can, if there's nothing else that you can do, put a list together. That's at least a start. If you can show proof, it's better. So if there was a committee and you were helping set up a conference, all right, or something like that. If you can show the flyer from it, if you can do things along that, that's better. But at least show me that you're doing things. Okay.
It could be certification drills.
Yes. Okay.
Could be certifications or putting together a teaching project.
Say that one more time.
Certifications.
A current certification you have.
Oh, that you've got. Yeah. Like hyperbarics or putting together a teaching project.
There's a different section.
I would put that more under in your professional accomplishments, if it's a certification that you've attained or under continuing education. I wouldn't necessarily put that under professional development.
But the teaching presentation.
If it was a teaching presentation, yes, teaching presentations could be put in here as well. All right. Okay. Other questions on that? Okay. Community involvement. Anything that you have done in the community. Okay. Huh?
I don't think I have anything in that last section. So we're just gonna get.
All right.
Church involvement.
If you're looking, that's more community.
Oh, I thought we were talking about community. Sorry.
What is the ultimate goal for you?
To get a job.
No, for you. Ultimate career goal. No, I'm just saying, think of your ultimate career goal. If your ultimate career goal is going to direct you in a place right now is, all right, let's say when I came out into nursing, my career goal, actually when I first got into healthcare, my career goal was to be a trauma surgeon. All right? That went away very quickly. That went away after about 18 months. And I said, there's no way in hell I'm going to pull those kind of hours, spend that amount of time in school, do those type of things. All right? But when I got into nursing, the career goal at the time was to be a flight nurse. I did some flight time, and it's not the greatest environment for for family life and these other things for me.
Thank you so much.
Again.
Thank you.
But if I am looking for a job ultimately to be a flight nurse, then I'm going to see about trying to pick up memberships in the ENA and some of those critical care areas. As a student, those are the cheapest. It's the cheapest time to ever join any of those organizations. Some of those can be as little as $20, $25. Some can be expensive. The student for like the healthcare executive, American College of Healthcare Executives, I think as a student membership, it's like $400 a year. As a as an exec, it's like $1,600 a year. Okay, they figure you make enough as an exec that you can pay the money for it. But as you're looking at some of those type of things, if I've got memberships in those areas, then it automatically, as I sit on my camera, it shows me that you're interested and want to move toward a job in that area. So as I'm coming in for an interview and I lay my professional portfolio down and I'm looking for a job in the ER and I'm already a member of critical care nursing organization as an ENA and I've been a member of SNA, that's what we're trying to help you look toward and move toward. So if you don't have it,
Can we just type something on a paper that says hypothetically, if I'm going into a job interview for labor and delivery and I would join this before, and put it in here.
that's up to you. Okay.
I don't want to go and
know, right? It's like we can only put what we have.
Okay. Huh?
I said we're not going to get punished for like if we don't have enough, right? Because we can't.
I did last
We
time.
only put. It's just funny. It's like we only can put what we have right now.
What we're trying to do is trying to help you move in those directions. And will we punish you? We're not going to punish you. But I can tell you, I can already tell you, I've already had students who have said in this semester, all right, I don't believe in the portfolio anyway. So all I do is I put a piece of paper in and I just say, hypothetically, I'll do this. I'll do this when I get into my storage unit in the next 12 months. And so the whole portfolio is that direction. So that what we're trying to do is push you to that direction. And do we ding you on points right now in the early stages as we're trying to get you to get stuff done? Yes, because some of you haven't gotten it done and it helps push you to go back and get stuff. Will we ultimately ding you on points if you come in and you say, down the road I may join this, but right now don't have the money to, and so I won't pick up an organization? That's fine. And we're not trying to get you to spend money, but there are other things that you think, and we want you to think outside the box and think about if you are those of you who are working, or those of you who are involved in student leadership, things that you have done because you normally aren't, when you're thinking, your thought process is like this, and we want you to widen it a little bit and think outside the box. So am I going to ding you? No. Does that give you the opportunity to say, fine, I'm just not going to do it, put a piece of paper in? I hope not. Okay?
So just because like I'm not a part of any like associations right now, like, but that doesn't mean that in the future I won't. So
Like a plan. How about the online ones that we have?
Like a specific.
The goal is to try to start trying to push you towards some of those type of things. And there again, what's going to happen is hopefully as you're coming into your next job interview, as we talked and some of my students have said in their classes, in this class, they are in a job that they really don't like right now. Okay? And they are planning for their next job. That's what we're trying to help you put together so that as you go for your second, your third, your fourth job, that you're putting those together. So if you don't have things in it, that's fine. You can fix those as you go down the road. Okay?
So what about like community service that we've done, or serving, PTA?
We'll talk about that with community.
Oh, are we not talking?
We went back to professional development. There were still some questions there. All right, so community involvement. Community involvement. This is not that I'm the nursery leader in my ward, okay? All right.
Well, you can word it different.
Okay. Community involvement. They should do. Everybody who's been a nursery leader, I want to hire as a nurse. Okay. This is about your involvement in the community. Now, some of those type of things. How many of you did senior games? That's a thing that can go into community involvement. Okay. Flu shot clinics. Helping with marathons. Helping with a health fair. How many of you are merit badge counselors for the Boy Scouts? A couple of you. All right. Put that down. So you're involved with Boy Scouts. How many of you have kids that play sports? All right, if you have kids that play sports, you are a booster for that sport. All right, because I'm sure, especially if they're younger, you've had to bring treats and all those other things to those type of things. What we're trying to get you and show is involvement in the community. Okay, it's showing you as there again more of as a three-dimensional individual, not one that just comes, does their job, goes home, and says, "Screw life, I'm just going to sit home and Facebook the rest of the day." All right. If you have anything that has been a clip that has been put you in the newspaper, all right, that's involved. So whether it is something for the holidays about, what was the one that the school dish did with all the bears?
For primary children.
They were getting bears for primary children to take up to the kids at Christmas, something along those lines. That's what community involvement is, okay? If you help with PTA, if you help with your kids reading in their classroom, all right, you can put down those type of things, okay?
College athletics.
College athletics, you can put in there, okay? All right, questions on that? All right. This is where we get all the questions, okay? Unit measures. Unit measures shows to an employer that you are involved on your unit, that you are worrying and caring about more than just coming in, slapping a tray down in front of your patient, throwing pills on the table, and collecting a paycheck. These are things that are tracked on your unit. Okay, they may be falls, it may be hand washing, it may be patient satisfaction surveys, it may be employee satisfaction surveys. It may be that we are looking to. I have one unit that they were looking at decreasing the amount of hand-entered punches. All right, that was the goal of the unit. That's the only thing that the unit was tracking. Okay. Pull up. They usually put a flyer out on a monthly basis that said, "This is where we are. This is how we've done." Get a copy of that. Put that into your portfolio. If it's patient satisfaction surveys, some of you are in and they have your patient satisfaction surveys, and if you're Intermountain, they throw a booklet out on the counter once a month or once a quarter, and it shows this is where our unit stands. Make a copy of the pages that apply to nursing. If it's about, doesn't matter. How does that apply to you? Because you are involved in that. You are involved in making and adjusting that. If it's falls and you have 46 falls on your floor, okay, last year. This year we had 4, okay, year to date. Then you have been involved in trying to do that. Let's say I had one that I had an ER and our patient satisfaction surveys were in the toilet. They were the worst in the organization. They showed that on an average, we had less than 5% of patients were satisfied with the care that they received. Okay? Someone said, I would never put that in because it shows that what horrible ER I worked in. I would sit there and I would argue with that and say, no, put it in. It shows we know that we have a problem and that they're going to say, well, your patient satisfaction scores and your unit measures were pretty poor. Yeah, they were, and we've been working on it, and these are the programs that we've been implementing and what we're trying to do to make sure that we are improving our scores. And they go, oh, okay, talk to me a little more about that. What do you mean that you're now making sure that you're doing follow-up phone calls? What do you do about these follow-up phone calls? That's where it's an opportunity for you to be able to talk and sell yourself and be able to make yourself more three-dimensional. Okay?
I'm not in a hospital setting at all, so this kind of stuff is...
What for everyone else, what's your setting?
I'm in an outpatient radiation oncology.
Okay. What do you track in your outpatient oncology radiation?
What do you mean by track?
Is there anything are there any checks that you do? Are there any things that you check with patients that you are tracking on a consistent level?
We check like their PSA levels and things like that.
Okay, but I mean that you're measuring. Do you measure overall radiation output levels and compliance with your badges or doing things like that? So.
I mean, like not like on like. I mean, like I'm sure that's happening, but like not that like as nurses like they made us aware of. Like.
Okay. Do you wear a radiation badge?
Yeah.
Okay. So if you wear a radiation badge and you talk with your boss and say, hey, is it possible that I can see that for, as I'm trying to put something together for a class about how we track our radiation and some of those type of things, because they track it in a graph.
Right.
And put some of those type of things in.
So if I can't get that information, can I just write about it? Like, can I
If you
Or is it as far as like, I mean later on if I can get that information and put it in the portfolio, is it as far as like for next week?
If you cannot get something along those lines. I had one that the manager actually said that that patient satisfaction scores were proprietary and no one could know about them except administration and the nurses. Is that true in a hospital? No, because they have to report them to the government and they're posted on the web. So they can get them along those lines. But if in this one they said, let's say that your facility, because of an issue that they had, was saying we're releasing anything about our radiation data. Okay, you could put in there you could put a sheet in there that says wanted to put in radiation data tracking. Manager said this was proprietary, would not release that. Although that's probably you can pull off the web as well because the regulatory commissions require that that's available to people. What we're trying to do is, if you can't get it, tell me why. If you're not working, let's say I still don't have my first job in nursing, and I haven't done any, been able to acquire those type of things, then tell me that, okay? And we'll work with you. Look, you know, if you're not a nurse, or if your boss says no, I won't let you have the data, I can't penalize you for that. All I'm trying to do is trying to help you with your next job.
Right, and I totally understand that. And so as far as like, and so I'll try to find the information I can. As far as the clinic, like I just might not be able to get that information.
It's fine. Just put the note there.
Writing down.
Okay. Other questions on portfolios?
So I got some points docked during the third submission,
Uh-huh.
and I fixed it now. Will you go back and look through?
When we go back for the final submission, we will go back. Now, last night I had some people who turned in their portfolios, portfolio submissions early, and so if I had those there, I went back and I corrected and added points in. Understand this: the portfolio is not a place that you say, "Oh, you didn't do it. We're docking your points. We're purposely bringing your grade down." No, it's not. If for some reason you got point stock because you didn't put a submission in, it's not the end of the world. You know, let's say I didn't have my job description, so I didn't put a job description in there. If you add those back in when we come in for the final submission, we're going to put those points back in. The only time you will be docked for points and you will not get them back on a portfolio is if you hand a submission in late. I had one last semester, and he handed every portfolio submission in 5 days late. So he lost those 45 points on every 45 percentage of his points every submission because he handed them in late. He says, you know, it's how I am. I just hand things in late. So, but if you come in and say I didn't have it, but now I have it and I'm putting it in, you're going to get the points back. Okay?
So are these due today or not?
Mine are due next week. So I don't know. I'm pretty sure Troy will probably do that, but I cannot speak for Troy.
This is the last submission, right?
This is submission 4, and then there's the final submission.
What is that?
The final submission.
Is there more things than the final submission?
That's why mine, because I wasn't here and there were some questions, I delayed my submission. So. Okay, portfolios. Completed, the final submission for portfolios is due April 22nd.
What would you like the difference between our fourth submission and our final submission?
Anything that has not been, anything that we said, you know, we dinged your points, like some that I dinged points on in the first go around. Let's just say submission 1, they didn't label their tabs, or something along those lines, and so I dinged them 5 points on it or whatever. That was what I'm going to come back in the final submission, and that's the final submission is where you've made corrections, and that's where I'm going to be checking.
So if we're turning them in on the 15th, how are we going to get them back? Add stuff to turn it back in.
You turn them in on the 15th, and I am going to try to have them back for you that day.
That
you guys have a class immediately following? You have Gaia's class. Okay. My goal will be to try to have those ready for you, so when I leave, that they will be ready before you leave that day for my class.
So we just submit it next time and then be done, or do we have to submit
It's up to you.
the second time?
If you have, and I've had those that have come through and they haven't missed any points all the way through. If you haven't and you say, I know I've got all this done and I'm going to be fine for my points, or I don't care, then just put me a note on it. Say this is my final submission also, and I will grade it at that point. Okay? Other questions? Any questions about leadership between now and the end of the term? One more exam.
When will you open that test?
Huh?
When will you open that?
When will I open that exam?
Release the question.
Or release what's required.
I will release the questions for it a week before it's due, and it is exam 3 is due the 29th of April, so it will be released a week. It will be released on the 22nd.
Why is it worth $350?
Why is it? Because that's what it's worth.
Yeah.
It's a lot of points.
It is.
Is it going to be like
It will be no different than the test you've had up to this point. It will be like the test you've had to this point. It is not comprehensive. It is over the last section of our material. Is it? I don't know yet.
Yes.
Sometimes they are, sometimes they aren't. We haven't decided yet. Okay?
Yes.
Okay? I doubt you'll be here for 3 hours. Maybe 2 hours and 57 minutes. For next week, because of the issues, we're moving the quality lecture to next week, and so next week we'll be discussing quality. Okay. Well, you couldn't have done the too much of the discussion because the quality we haven't had yet. So I haven't graded anything. So if you think, so those that say I already did all my quality stuff, you haven't done it yet because we haven't had the lecture. Okay. So what did you have last week? Future of nursing.
That's not one of our things.
What we had was this. What you had was this because. Okay. Last week was supposed to be quality. All right. Troy moved leaders as educators and future of nursing up and covered brought that together last week. We were supposed to do quality this week, and we were going to do in its place because next week was risk management. Karie couldn't be here next week because she has to go to court, and so she asked if she could move her lecture ahead a week. So what we've done is we've moved those 3 lectures around, and so what we're doing is we'll be moving quality down to next week.
So copy what we put in the quality journal entry into
your quality journal entry. I don't know. What you did as leaders as educators I haven't even graded the quality reflective journals. So if you have put in from last week for quality, then put that down for your future nursing, and then we'll do quality next week. You can adjust it because I haven't fixed it. I haven't graded anything for my class. You're so confused. We juggled all 3 weeks of classes back and forth. If we haven't had the class, nothing has been graded other than I graded your modern healthcare stuff.
So we have a movie discussion, a conflict discussion. Do you know where we can get that for free so I don't have to spend money on it? It's not on Netflix.
Oh, it was on Netflix as of a few weeks ago. I will see. It's on, a lot of times they're on YouTube as well. Okay? The Guardian.
Oh, I saw it. I actually watched it like 2 months ago on TV.
That's between you and your instructor. Okay?
I really did.
All right. We'll see you next week.
Sorry, 2 weeks in.
All right. So what we're talking about.
Yeah, so I bought the book and read it, and then like I couldn't believe that I could answer the questions, but I still had to have the Yeah, it was really good.
All right, so we can do all right, so that's what I think. Because I had some.
I tell you that.
So that's why
I tried
prepared. So professional credentials.
Capability of that. I don't know why, because I haven't.
That was just. Drop your CPR card. So the assignment was all these zeros. Now,
makes me question about the Barbie.
So this got yeah, what I do is
Sorry, am I interrupting?
that way, anybody wants to know. Go to cash. Okay? Does anybody not get it from our class? You saw this part of the row?
Yeah, sorry. Sorry to be a front row student.
Fine.
Sit there and you talk to him.
Oh, okay.
So in there, it's there.
I know, all my certifications are in there.
What are you going to do? Is everybody else ready to present? Yeah, so I got that. So after you send that, I'll email it and then yeah, absolutely. I have to go print out too. Yeah. Am I ready? I mean, like, I've been ready to come back yesterday so far. How was your vacation? To the hotel. Oh, good. All right. Oh, thank you so much. Yeah. You guys are getting on that. Oh. They all do it. They were all out of shape. They kept taking our the mother out of her state. I could do it over and time. I do it.
Well, then you should have said something.
Well, I don't think they were relying on coaches. So I think one of the things was just like learning how to make fun and continuing papers. So it's great. It wasn't bad. I just thought I worked Thursday. We've learned. Next time we won't have a taper for state where we all have them pop back up and just work. Because see now the schedule. Yesterday at night.
Pretty good.
Well, but these guys were down to like, Kelly's practicing an hour. The last 2 weeks. An hour a day. So he So he's okay.
11?
He'd added 7 to his time.
I had a lot.
500 feet.
11 would be
cheap up Lance didn't say, he just said I think he was concerned. I should really say but I think he talked to Alicia tonight because of her state Kayla could say you're I might have to because she started tapering her senior and then
with Michaela, she would get out of the water an hour early. So Michaela's a different story. Jared, Kale, all of them, they both in the water. I will. I realized that for a year, and like I got to do I think, and now I'm like, I don't know, you should read some of it, and it's like $100. I have to.
Well, you usually
No. Oh, I got like 1.5. Oh, you're so pretty. Oh my gosh, she's so gorgeous.
Hey, what's up?
Yeah, I know. Okay. Are you doing it? You are. You don't have to answer it. Just read from it. That's it. I can read it. Like this is great. If you don't like the paragraph, just delete it. I'm okay with that. I can do it on this.
I don't like it very much.
Yeah, he is he's one of our actual examples. A lot of people really
I didn't see it.
I think sometimes you get it. But you know, in Utah,
Noelle and I are on the same team. Guys, I hate debate. Oh, that's right. And I might say the whole time because you were free. Like, it doesn't matter what time you're on.
And I think she really likes that. I'm waiting for the debate. Whatever I said to you.
But in today's market,
I recorded your whole
here, where if I went to Alaska, if you showed up with clothes on and speaking, you probably get hired because they're so they're not buying shirts. But I come walking in and I shut the door. You know,
and you thought, you won't get one.
I really didn't think you would.
it doesn't
You're gonna work hard. And he did. How many pounds did you
put that in there.
Are you sure? he stood up and my husband was like, spending muscle.
Wait.
He's just
Well, if you look at it, the way the portfolio is set,
Kale, you're so cute. I do that to my own kids. Oh my gosh, I gotta call my
Go play your kids.
There's professional credentials, diplomas, and those types
So I haven't taken the tag off this yet.
This is professional credentials. That's graduation.
What? You knew that? I'm a consumer. I don't have to see what they want me to do just because I bought it.
Alright, things like that. That goes here. Continuing education.
No, never. Not that. I mean, like, not underwear, but.
I was like, I don't want the two touch my backpack or backpack.
No, like, never for that kind of stuff, but like, for this kind of like actual consumer, not just like, putting it on my body.
And although it talks here about
I feel well, yeah, but it's not like against my body. It's not trashing it. And like,
because as I'm looking at this, and this is actually
but I'm gonna keep it. I decided like an hour ago that
I always get Karie and I walk in and like,
they're gonna say, come in and say, oh, what have you done?
I like the thought process. Yeah.
Jen, did you change your height? How are you? I don't want to do that.
Like a leadership
How are you? Okay. I haven't done that yet. Look at all that, like, Becky's the only one that's funny. Okay.
It's not
such a priority
for me.
Okay,
Yeah,
good.
I started the slideshow. I did start it. I put her stuff on.
Okay.
So it is like the format I've got.
Okay.
So
all right. She just wanted to make sure that was okay. She's out of town right now. I'm like, I need to get all that.
Yeah, well, by the time I get my stuff, then if you get your stuff,
Yeah.
it'll be fine.
Okay. Well, thank you so much.
Oh yeah.
Appreciate it.
See ya.
See ya.
For me, like, I was, it was my first year. It's kind of a nice transition to a college. Yeah, right. Yeah, still not like out of job. Yeah. I noticed a lot of people that have issues, or like, you know, like the popular kids that high school that have a counseling one, and they're like, oh my gosh, I don't know how to be in this person. And I was never like that in high school, but I thought the Cal program was good for people who were like that because then they were able to friends and like stuff. I don't know. So I think just like in general, I'm like transitioning into college in the first place.
I think most kids coming into college have no clue about what they need to be doing.
Yeah.
Really, they don't. And
it's a good, you know, way to get you on your feet, I think.
I told my son I struggle with the fact that the state pays for Canvas and pays for all this stuff for the universities, and they already have it set up. Why aren't they using it in high schools? You know,
Yeah,
I have teachers who come in and say, "Sorry, you didn't turn your paper in." I turned it in, and I got to the point where I had to have one of my kids every time they handed in an assignment, the teacher had to sign the book form. They signed it and date it. That said, professional portfolio submission 4, and then I would have to sign and date it that they received it because they would lose it.
Yeah.
And said, you didn't turn it in.
I did.
Okay, I'll give you the points. But if they had Canvas and the kids being able to do it that way, it would be so much easier. As I grade it here, it automatically goes in the grade book. You know, one of the things instead of do it on the paper and then I'll get around to it in a week or so. So I just think that it would be better, but thank you for shutting down the system. I didn't know they were shutting down the system. Okay. So
That should, I wonder.
So you're working with Brian now?
No, I just I opened up an ice cream shop in Lehigh, and he lives in Lehigh, like down the street.
So you're running an ice cream shop now?
We sold it in October, but I was like, he and his wife would come in all the time, and we got talking, and he was like, oh, I went to UVU, da da da, and then anyway, so I'd always ask him questions when he came in. He's like,
Brian
okay.
used to come in, and he would come to class in flaming blood red scrubs every day of the class. And he stood, and then he would sit in the front row, so you could first thing in the morning. So
hey, I have a question for you. So my husband just applied for a job out in Tooele. It's like at the base there.
Oh, at the depot?
Yeah, do you know anybody there?
Do I know anyone at the depot? I don't.
Okay.
It's been.
I figured I might as well ask.
I've been out 8 years now out of the military, and
He applied for, like, it's a job where you buy all the supplies and everything.
Oh, uh-huh.
Is that a cool job? He's trying to figure out what to do with his life. And I was just wondering if you knew anything about that.
If
what
it
is, I don't know.
It sounds like he's in the purchasing department or the materials department.
Yeah, something like that.
He'll just, depending on what it is, his level there, then he'll be, when things have been approved by the government that this is what you'll buy, it's kind of like the hospital. They'll come in and say, we only use angiocaths. So he'll be making sure that we're getting angiocaths in and phasing the others out, making sure that those have happened.
Is it like a good place to go, or is it kind of a dead end type of job?
It depends on what he ultimately wants to do with his life.
Well, he has his own business and he sells like lights and
He sells bikes?
lights.
Oh, lights.
Like
Okay.
bulbs and
Uh-huh.
equipment to hotels and stuff.
Uh-huh.
And so, like, when he pulled up the job, he's just been looking at. He wants to like get a job with the government so that he has a retirement program.
Yes.
And he wants to just continue to do his lighting business on the side.
Uh-huh.